So when it comes to insulin, we are very clear. Insulin remains the golden drug of choice and is recommended for pregnancy because it does not cross placenta and has no adverse effects on the fetus. So given a choice, every pregnant woman whose glucose levels are not on target with MNT and lifestyle should be given the choice of using insulin for glycemic control. In certain situations, such as if it is a mild case of dysglycemia, a mild GDM, or in resource-strapped situations where the lady is not accepting insulin, cannot take insulin, or there are some real challenges to insulin therapy, in some conditions, DIPSI guidelines also advocate metformin that can be started in pregnancy provided the gestational period is more than 12 weeks. So metformin in restricted situations can be used. Of course, in PCOS and other conditions, the OBGs actually swear by metformin, which is used for ovulation induction, but the guidelines clearly say that metformin does not really prevent onset of gestational diabetes, neither does it reduce spontaneous abortions. Therefore, there is no real use of continuing metformin in pregnancy. So when it comes to insulin, what are the regimes that are recommended in pregnancy? Again, if it is gestational diabetes, which means only a postprandial hyperglycemia, where the fasting levels are essentially normal, only a bolus insulin or a rapid acting bolus can be given with whichever meal the glucose levels need to be targeted. Of course, if it is pre-gestational diabetes, where the postprandial and the fasting both are above target, that is where a basal bolus regime works well. So whichever meal is above target, a rapid acting bolus can be given pre-meal, and if the fasting glucose are not on target, for that we can give them a basal insulin, which can either be a Levemir or a Detemir insulin, which is safe in pregnancy, or maybe an NPH if we are using a conventional insulin. So when it comes to the debate whether conventional or analogs to be preferred, again data very clearly says that both can be used. There is no particular advantage of one over the other, although the rapid acting analogs do have a predictable and a faster action when it comes to controlling the postprandial glucose. So any of the conventional human insulins can be safely used in pregnancy. So be it an Ectrapid, be it a human insulin R, all of them can be used as bolus insulins, and an NPH or an Insulatard can be used as an intermediate acting insulin. If you are using analogs, both your Aspart as well as Lispro are safe in pregnancy. Data with Glulizine is still limited. If it comes to the basal insulins, Detemir insulin is safe in pregnancy. Now there is data which says that if the lady is already using Glargine insulin as a basal insulin and has good glycemic control, it can be continued in pregnancy, and there are no major challenges if the Glargine is used in pregnancy. So I think now we are very clear. In pregnancy, insulin is to be preferred. In situations where insulin cannot be used or is not acceptable, metformin can be given. Of course, if there is IUGR, preeclampsia, hypertension or a complicated pregnancy, then it has to be insulin all the way. In some situations where high doses of insulin are required, maybe in the last trimester, that means in the third trimester, metformin may be added in such situations to reduce the insulin doses. So with that, I think I'll finish. Thank you so much.